Good afternoon, everybody. Thank you for joining us for the Tick-Borne Disease Clinical Education Series webinar. Today we have with us Cynthia Christie, who's an attending physician in pediatric infectious diseases and a professor of pediatrics at the University of Rochester, and Eric Ingorowski, who's a practicing physician here in Rochester, a clinical instructor in pediatrics at the University of Rochester, and our pediatric section editor here at VisualDx. I'm going to turn the presentation over to Dr. Ingorowski.
So our case today is an 8-year-old previously well girl who presents to her primary care doctor with a 3 to 4 day history of fatigue, low-grade fever, malaise, lack of appetite. She denied any vomiting, diarrhea, cough, runny nose, sore throat, or abdominal pain. Some additional information: she resides in upstate New York. This case occurred the end of May, beginning of June. 2 weeks prior to presentation, she had traveled to Long Island to stay with her grandparents, where she engaged in many outdoor activities, playing in local parks, picking some berries. She's also pretty active outdoors at home, playing in her backyard sandbox. They report no recent illnesses, and she has no chronic medical problems. Her vaccinations are up to date, and she is not in daycare, but does almost daily. Her medications during this illness are just reported as acetaminophen and ibuprofen is needed for the fever. On exam, the child appears well, but is warm to the touch with a measured temperature of 101.5 on a temporal thermometer. She's mildly tachycardic with normal blood pressure and oxygen saturation. Her HENT exam is normal, lungs were clear, heart exam was normal, abdominal exam also normal, and on neuroexam, she's alert and oriented with no focal findings. Her skin exam does show a small lesion that is located just above her underwear line. And this is the lesion that we saw in the patient.
So I thought I would just describe the lesion. It's small, it's oval, it's a faint pink color around the table and around the internet. It's rather nonspecific. It's maybe an early picture. Let's go to the next slide and we will talk about what we might be thinking as a differential diagnosis. So the question we have is, as we do when we see many patients, is do we have one diagnosis here or two? And for the purposes of this presentation, we're trying to pull it all together into one. Viral illnesses like enteroviruses or like EBV or like mumps. With each of those entities, we would expect a more. So could this possibly be a mosquito-borne viral infection such as West Nile or Eastern equine encephalitis? That doesn't really fit because both of those have a more neurologic presentation, which luckily for her, she does not have. We also should think in the summer about tick-borne illnesses such as babesiosis and Lyme disease, and a newer rash illness called Southern Tick-Associated Rash Illness, and we will discuss that later. Other things we might be thinking about would be rickettsial pox, which is a rickettsial organism that from the house mouse, and it causes a papulovesicular rash with an eschar, which this patient does not have. Cat scratch disease usually does have a rash. Tinea corporis is common, so that doesn't seem quite as common. Atopic dermatitis to either chronically or to a new contact, it's only one lesion. That doesn't really fit a presentation of a bug bite or a bed bug. In the picture, it might be an arthropod sensitivity reaction to a tick bite. With that kind of a rash, you would ask for the history. Did someone bite you there? Did you have a tick? And that kind of rash sharing, hopefully, of a child, and that one also looks like there's some palatal petechiae too. But again, as we mentioned on the slide before, we would also expect some characteristic lesions of hand, foot, and mouth on the rest of the child too. C is a picture of starry, which we're going to talk about in the future, but the southern tick-associated rash illness. And then D is a fairly classic large erythema migrans lesion in a patient with Lyme disease. We have in A picture of a child with measles, so it's measles-like or morbilliform, so diffuse maculopapular rash, which is pink to red. In this child, you'd expect fever, cough, coryza, conjunctivitis, dermatitis, which means round dermatitis. And as you can see, if you look closely in this beautiful image, there is some scale and no central clearing. So this patient, and this is probably pruritic, so it doesn't really fit our patient perfectly. So we got some more history from the patient, which was fairly unremarkable. She'd had no falls or injuries. She'd not been sick. No one in the family had been sick. You know, when on the vacation had been sick. They don't have pets. Great. So we tried to narrow our differential diagnosis into the top 4 things, which would be, is this possibly Lyme disease? Is this just an insect bite and it'll go away on its own? Is this a child that's getting a nummular dermatitis that's flaring in the midst of a viral illness? Or is it starry, southern tick-associated rash illness? What we'd like to talk about a little bit is some general things about Lyme disease. It can present with nonspecific constitutional symptoms of fatigue and malaise, such as our patient has. It's transmitted by the deer tick Ixodes scapularis, which is endemic to New York. A characteristic skin lesion is the targetoid bull's eye appearance of erythema migrans. 60 to 80% of patients present with the EM rash, usually 3 to 30 days after the tick bite. Other later features can include Bell's palsy or facial palsy, carditis, arthritis of a large joint, most likely the knee in a child, or even meningitis. We have some nice pictures of typical and atypical rashes associated with Lyme disease. The top 2 show large lesions with a bullseye-like appearance. So these are not tiny little rashes from a bug bite. This is an enlarging rash, and then both of them have the red in center. The more atypical rashes are the lower left shows a little pustule or a little vesicle right where the tick was attached, and some very mild erythema. Be careful about is it's not necessarily always a round lesion. So on this patient in the lower right, it's more of an oval lesion. All right, what is this starry disease or southern tick-associated rash illness? Well, we don't know a whole lot about it, but we do know that it is associated with the lone star tick. And this is a picture from the CDC that shows where that tick lives. And on the next slide, we'll show you that the rash is a bullseye at the site of a tick bite. It appears a little earlier, 1 week after the tick bite. Common symptoms, again, nonspecific: headache, low-grade fever, muscle aches, and fatigue. The cause of this is unknown, and thus we have no confirmatory diagnostic tests at this point. People have tried antibiotic disease, but the skin lesions are often single, and they're smaller than in Lyme disease. How do we figure out if this patient has Lyme disease or not? Well, in our patient, if she has a characteristic rash and she was in an endemic area, and even better yet, if the family said, yes, we took a tick off, we would say this is classic Lyme disease. it's early Lyme disease, and therefore we treat without any serologic testing. If it's been longer than 2 to 4 weeks, we can look to do serologic testing. The classic serologic testing is two-tier testing, where there's an ELISA that's done for the detection of IgM and IgG antibodies, and if there's a for a Western blot, which detects IgM and IgG antibodies to multiple individual components of the spirochete. Of note, a negative Western blot rules out Lyme disease. It is the gold standard. Some labs have replaced this with a newer test called the C6 peptide assay. Outside of early disease, it's very comparable in sensitivity and specificity to the two-step serologic testing. And so that's made it easier for labs to do the testing right on site rather than sending some of the sera off for confirmation for a Western blot. What are some risk factors for Lyme disease? Well, being outside in an endemic area. So in the Northeast, Midwest regions of the U.S. Being around any pets like dogs or cats that go outdoors. Exposing the skin while in risk areas. And the next risk factor is not removing a tick promptly, because these ticks have to be on engorging themselves for 36 hours to actually transmit the organism. So they have to be on for a long time. Well, that sounds easy, except these are tiny ticks, these black-legged ticks. So it's not as easy as it seems. General symptoms, generally the rash presents where the tick bit the person. They can be nonspecific flu-like symptoms, as our patient had. You can have other symptoms such as unexplained cyclical fevers, fatigue, headaches, dizziness, neck pain, stiffness, lymphadenopathy. About half the patients can have abdominal pain. Urinary urgency or frequency has been described. Aches and pains have been described, and sleep disturbances. The most common neurological problem seen in Lyme disease in children is Bell's palsy. Just to review a little bit more about the erythema migrans rash, typically begins as a small, less than 5 centimeter, gradually expanding annular rash that does get better, bigger than 5 centimeters as the patient has it. It presents 1 to 2 weeks after the tick bite. About 60 to 80% of Lyme disease patients will present with this. It's usually painless, it doesn't itch, but it can be associated with pruritus, burning. That has been reported. They can occur anywhere on the body, but most commonly in the groin, axilla, waist, back, legs, and in children, the head and neck. Characteristic lesion is, as I mentioned before, the bullseye appearance. Actually, 2/3, even though the bullseye rash is characteristic, most people will have a uniformly erythematous circular rash with maybe some enhanced central redness without clearing around it. So even characteristic doesn't mean that everyone has bullseye target lesions. I just want to make that clear. Other things that are more strange would be a fasciculobullous lesion with central vesicles and bullae in the middle of the circular rash. How do you prevent Lyme disease? Stay inside. That's a joke. Avoid exposure to ticks. Yes, so how do we do that? Well, pretty much you can prevent deer from coming into your yard. I'm not sure how effective one is with that, unless you put really high fences around it. Clear away underbrush and cut back shrubbery, such as DEET on the skin and permethrin on clothing, which kills ticks on contact when outdoors or when traveling, where ticks are endemic. The Infectious Diseases Society of America has a guideline for how to treat Lyme disease, and also it gives criteria for when you might consider prophylaxis with antibiotics after a tick bite. And to do that, they suggest we fulfill all of the following conditions. Doxycycline, remembering doxycycline is not contraindicated in the patient because doxycycline is the only approved prophylactic antibiotic for Lyme disease. The attached tick is identified as the correct kind of tick. It's a small tick and it's not a dog tick. And it's been attached for approximately 36 hours. Post-exposure prophylaxis is started within 72 hours of the tick removal, equal to 20%, and that's something you can find out from your local health department. Do I live in an endemic area? And if these criteria are not met, the best advice is to watch that lesion and see what happens over the next day or two, or over the next month. And just to sum up, the preferred treatment for early Lyme disease, which is what this patient had, would be to use amoxicillin, doxycycline, or cefuroxime. And I believe our patient was 8, so we could use doxycycline, which in this patient. You have other types of Lyme complications that are not complications and later stages of Lyme disease, which we didn't really go over today.
I think one key thing to remember for the peds folks is we usually use amoxicillin BID, but this is a TID dosing regimen. So.
Oh, thank you. Thank you for that. That's great. Well, we're hoping to get some questions. Well, Dr. Ingorowski, tell me about taking off ticks off children.
So we frequently have patients call, parents are actually quite upset when they find a tick on their child. And sometimes they'll either come into our office for removal or they'll have removed it at home and bring the little sample in the baggie. Identification of the tick is always hard. We went to medical school and we're not entomologists. And unfortunately, rarely do we have a full tick to look at. So sometimes we can get a little gander from the tick as whether it's engorged or there could potentially be a deer tick versus a dog tick just based on size. But sometimes that can be pretty hard. For removal in the office, we do have some special tweezers we use for that, but it can be a bit of a traumatic experience. The mouthpieces are very intertwined in the skin and deep, and frequently the mouthpieces will remain intact in the skin, but the body will be removed. And that's a pretty common occurrence. Often we'll frequently see a little bit of a rash at the site of almost any tick bite, and that really probably has to do more with the hypersensitivity reaction to the saliva of the tick and the anticoagulants that they kind of secrete so they can have their blood deal without clotting. So sometimes we can't even make a call in the office. We'll have the patient watch the rash for a few days before we'll make a determination of whether we're going to commit them to a 21-day course of antibiotics or not. And again, serology often at that point may not be useful because it's too early.
Yeah, I think that's very helpful.
So we do have one question here. Can you get Lyme disease more than once?
Well, unfortunately, you can't. You were living in an endemic area when you got it the first time. You still live there. You were treated appropriately. And we present again with what might be a typical rash for Lyme disease. The problem is, how do you make the diagnosis then? Because the patient most likely has positive serology from Lyme disease from the first time they had it. So at that point, because it is going to be difficult to make the diagnosis using serology.
Have another question in too. Is 21 days the recommended duration for antibiotics?
So I think we have to go back to our slide of the treatment for Lyme disease. Yeah, it looks like it's 14 to 21 days. So I think that's reasonable to say yes to that question. Thank you.
Two more questions coming in. One question, when do you look for co-infections with Lyme?
Well, I think what's reasonable, because unfortunately, Anaplasma and Babesia can be in the same areas where infected ticks for Lyme disease are. So I think it's reasonable after a week or two, if the patient isn't getting any better for the treatment for Lyme disease, then it might be a time to try and confirm other infections by doing serology for those.
Now the question is, if the head remains in after tick removal, do you have to remove the head?
Well, you taught me earlier today that that can be impossible.
So in the office, sometimes we have significant difficulty removing all the mouth parts. And what we have done in general is most of those mouth parts will come out over time. So we just apply a little bit of triple antibiotic to the area, and usually they will detach as
the skin grows and the body sort of sends it out.
Those mouth parts, though, prevent very little infectious risk for getting Lyme. So the risk really comes from the thorax and the abdomen, where the blood is mixed with the Lyme-causing organism within the tick's gut. So once the body is removed, there poses very little risk of the remaining parts posing a risk for causing Lyme.
But it does cause mental distress.
Yes. So can you speak on the varying presentations for babesiosis and treatments? Not
very well. To be quite honest, I can speak that the treatment of Lyme disease will not treat babesia, so that's why I recommend getting specific serology and then looking up the.
So if the patient has Lyme disease for over a year, is the recommended treatment different? So that would be someone who's found to have Lyme disease later. I'm imagining that person's diagnosed by serology.
Oh, correct. All right. So I think you treat as if they had an EM lesion for the 3 weeks. And that might be the question. Maybe the question you're asking: what if someone says, please test me for Lyme disease. I've gone to Cape Cod for 4 years, and I want to know if I have Lyme disease or not. And as a doctor, you say, I really don't want to test you. You're feeling fine. You don't have any late symptoms. And the person says, I really want you to treat me or test me. And you say, finally, all right, I'll do it. And so then what can happen is you'll find that the person has a positive serologic test for Lyme disease. And from my reading, you might decide at that point to treat them once with an oral regimen for Lyme disease for 3 weeks.
Can children under 8 get Lyme disease?
Children under 8 can get Lyme disease because they go outside and they brush against brush, shrubbery, and grasses, and they run into those ticks. And so what do? We treat them with amoxicillin if they have early Lyme disease.
In a recent EM Core podcast, it was mentioned that doxycycline under 8 is becoming more of a soft recommendation. Do you feel that this is true?
I believe that is true. It is becoming a soft recommendation. And why is that? A couple of reasons. Number one, one course of doxycycline in a child under 8 for a potentially life-threatening disease is not going to stain their teeth. It's repeated courses of doxycycline. However, that's number one. Doxycycline will also treat a patient's anaplasma if they have co-infection. So that's sort of the nice thing about it. And then number 3 is doxycycline is preferred for Bell's palsy. So it does have a bit of CSF penetration. So the answer to that question really is call your local expert, talk to your group, and decide what you're going to do. Because it hasn't come out in the Red Book as a true recommendation. They say not under 8. Do you agree?
I would agree, yes. And for pediatricians, we've been stuck in this situation many times in life where we get forced to use Cipro in very young babies when it was originally contraindicated, and I think doxy is going to probably fall into the same category where we'll see lower and lower age indication over time.
An example would be a patient with Rocky Mountain spotted fever that is under 8 years old. It's a life-threatening disease. You use doxycycline for that. So I think this is an evolving, and as the questioner asked, a soft, quote-unquote, recommendation. So thank you for that question.
Okay, well, it looks like we don't have any additional questions. Oh, I take that back. Bear with us a second.
Read it. Will anaplasmosis present similarly to Lyme and babesiosis? Whenever there's a standout characteristic I can take home.
All right, truth be told, I live in an area that's endemic for Lyme disease, but not for babesiosis and anaplasma. There are some commonalities. They can have generalized nonspecific illnesses, different rashes, and I think the anaplasma has different blood abnormalities associated with it.
Okay, so it looks like we're going to wrap up. We don't see any additional questions. We just want to say thank you to Dr. Christie and Dr. Ingarowski for joining us today for that great discussion. And we hope you'll tune in for our next Clinical Education Series webinar. Thanks so much.